Welcome, ladies and gentlemen, to sqadia.com. My name is Muhammad Osama, and we are talking about data collection and medical statistics and research. And the topic that we're going to discuss right now is designing questionnaires, in which we're going to talk about the layout of a questionnaire, Likert scales, visual analog scales, and numeric rating scales. So starting off with the layout of a questionnaire is very important because it affects the completion rates and therefore impacts the overall quality of the data collected. Because things like if the questionnaire is too much cluttered, or if the font is too small, or if the questionnaire is too lengthy for someone to be interested in filling it. So these are the things that would actually affect, and the layout should be reviewed, and it should be in a way that would actually have the participants fill it correctly, and you would have a good quality of data. So there are some important points which you can consider to improve the layout of questionnaire, and thus in turn improving the quality of data. It is a very small thing, but it is very impactful. So especially when we talk about self-completed questionnaires, because the participant or the patient is filling that questionnaire him or herself. So the layout becomes very important, and the things that we should be careful about when we are designing the layout, the visual layout of that questionnaire. One thing is that give clear instructions and examples of how to answer questions where appropriate. So there should be enough instructions for the people so that they can give you the correct response which you are looking for. Make it clear and uncluttered. The language should be simple. The visual effect should be pleasing and simple and should not be uncluttered. Make it easy to navigate with any skips clearly mentioned. Like for example, if there is a question in series and if it has to be skipped, if you say or answer no to the first part, so make it clear so that the person can skip the questions and it will be easier for him to fill it. Consider size and length according to who will fill this in. If, like for example, if they're younger participants, or if someone you think they would not be so much interested in filling it in, so keep it short and simple. Indicate page turns clearly to avoid respondents missing pages, and also number the pages so that they would not miss that. For example, if they're turning from 2 to 3, they should see that, oh, it's the third page. It should not be so that if they turn out to the page number 4, they would clearly be identified, oh, I missed the page number 3. So mention the pages on the top right corner or the bottom corner, wherever you want, wherever it is, it suits best in the layout. Consider which fonts will best suit the intended readers. For example, if you are dealing with the geriatric population, you are getting the population from geriatric patients or participants, then the font should be big enough and clear enough, bold enough for them to read. And these are the small things that actually matter a lot. Piloting is very important, as we already talked about in the previous lecture, that piloting can help identify these problems associated with layout and other factors, and you can improve your questionnaire design based on your pilot study, and you do not have to revisit or redo the data collection procedure. Now, another question is, should we use an existing questionnaire or not? So my suggestion for that is always use an existing questionnaire whenever possible. What are the benefits for it? It is better to use an existing questionnaire if there is one that has already been tried and tested. So it means it has been validated, that its validity and reliability has been established, because that is very important. Whenever you send your manuscript to any journal, you need to mention its validity and reliability, and if it's a new questionnaire, you need to establish it yourself. So that takes a lot of work as well. Another benefit is that if it is an existing questionnaire, some other researchers may have used this outcome or this questionnaire in their research, and you can actually compare the findings of your study with those that are pre-existing, and you can write very interesting and good discussion in the manuscript, and that actually also would increase the quality of your manuscript and chances of its acceptance. But sometimes it's not possible to use that questionnaire as it is, and you need to modify it. And people usually ask the question that can we modify an already existing questionnaire? So the answer is yes, you can. But the problem is that whenever you modify it, it is not the same questionnaire now. So you have to establish, or you have to re-establish its validity and reliability before you use it. And that's all about using a new or a pre-existing questionnaire. And the same is that when you make a new questionnaire by yourself, then you once again need to establish its validity and reliability as well. Now, when you make a questionnaire or when you use a questionnaire which are already there, you see that Likert scales are very commonly used in questionnaires. So what is actually Likert scale? Likert scale is a scale which is used to record the level of agreement or disagreement with a particular statement, and it is by different options like strongly agree, disagree, etc., which we'll look at the examples. So these are discrete scales where respondents have to tick one of the number of the replies to either express agreement or disagreement. And the example is, for example, I can get an appointment with my general practitioner whenever I want. So the responses are strongly disagree, disagree, neither agree or not disagree, agree, and strongly agree. So here you can see that there are 5 options and there are actually odd number of choices. So whenever there is odd number of choices, there is a neutral response in the center, and then there are responses as disagreement or in the sense of agreement on the both sides. But sometimes there can also be even number of responses, like this question here. General practitioners should provide appointments outside normal working hours. Strongly agree, agree, disagree, strongly disagree. So there is no neutral response to this question because there is even number of responses. So some people believe that Likert scales always have odd number of choices, but they can also have even number of choices. But the thing is that they always need to be symmetrical. Now, what is meant by being symmetrical? These two figures can actually explain how. So you can see if there is odd number of responses, so the center one is neutral, like for example undecided or don't know, and there are the same number of responses on the right hand side and same number of the responses on the left hand side. So same number of the responses on the agreement side and same number of the response on the disagreement side, and one in the center. So this is called being symmetrical. Similarly, there is no neutral when there are even number of responses, but still there are equal number of responses or choice of responses on the disagreement side and the agreement side, and which means it is a symmetrical type of question in a Likert scale. So the choice of verbal label varies. It is not necessary that it should be in terms of satisfaction and dissatisfaction. It can be different. For example, the Likert scale has been extended to apply to numerous situations. For example, response to pain medication or patient satisfaction as well. So how was your pain since you started this new drug? So worse, no change, or better. So you can see there are odd number of responses and it is symmetrical, so it is a Likert, but it does not have the response mentioned as satisfied or not satisfied. So which means that Likert scale can be used for many purposes. On the other hand, conventionally, if you see how satisfied were you with your last clinic visit, so very satisfied, very dissatisfied, fairly dissatisfied, neither dissatisfied nor satisfied, fairly satisfied, very satisfied. So now here is a dissatisfaction and satisfaction type of response. So it can be used for any purpose. Now, statistical analysis of Likert scale data. The key characteristic of Likert scale is that the scale is symmetrical. Secondly, it is categorical and it is conceptually evenly spaced. This leads on to how we code and analyze data for these scales. So these scales are usually coded symmetrically. Like here we have an example. The neutral response is 0 and the positive response are +1 and +2, and the negative responses are -1 and -2. So because it is symmetrical, so right hand side plus, left hand side minus, so symmetrical responses, and the coding is the same as well. But sometimes Even though a numerical code is assigned to the responses, we need to understand that data is ordinal because it has an order and it is discrete, it is not continuous. Hence, an average may be misleading. I cannot calculate an average of saying 1 point minus 1.5. Now, what does that mean? Now, that has no meaning. It is not purposeful. So, it is not continuous. So, you cannot calculate the averages for it or standard deviation, etc. So, where there are responses to several Likert questions, the responses sometimes sum to give an overall score, such as in question like neck disability index. Neck disability index has a score for overall questionnaires, and some questionnaires even have a component score. So those scores, however, on the other side can be used as continuous variables, and they can be used for averages, etc. In this case, it may be responsible to treat it as a continuous variable and calculate means for analysis. As we already discussed that Likert scales are symmetrical, but sometimes we have a scale which is not symmetrical, or a question which does not need a symmetrical scale. So in that sense, we need to use other response scales other than Likert. So not always appropriate to record replies on a symmetrical scale. For example, when recording pain, we can also use no pain, mild pain, moderate pain, severe pain. So this is the neutral response, which is 0. But there is no response on the other side of the neutral response. So it is not symmetrical, it is asymmetrical. And sometimes we need asymmetrical responses. So it means whenever we are looking for asymmetrical responses, we cannot use Likert scale. So here we can be used as, quoted as 0, 1, 2, 3, instead as -3, -2, -1, 0, +1, +2, +3. So that would be a Likert scale, but this here, it is not Likert scale. So data here is ordinal, and once again, it is categorical and it cannot be used as a continuous variable. Visual analog scale. Now this scale, on the other hand, is a continuous scale, and it can be used as a continuous variable, and you can calculate the averages and means and standard deviations out of it. So visual analog scale is used to assess intensity of symptoms, pain, quality of life, etc. And it is used to assess pain in a lot of studies. I have myself used this visual analog scale in a lot of studies. And it is actually a horizontal line, which is usually 100 millimeters or 10 centimeters. And the patient response is calculated based on the mark he puts on this line, and you calculate the length. So let's suppose a person mark line here, it is 1 centimeter. So 1 centimeter would be the response, or 10 millimeter. That would be the score of that participant, with 0 being the minimum and 100 being the maximum. So length needs to be carefully measured for accuracy. This line should be of the accurate size of 10 centimeters, first of all. And second of all, it is very important that when you're photocopying that form or questionnaire, it should stay of 10 centimeters, because if it is changed, then it induces bias and the results are not valid and reliable. So the data out of it can be treated as continuous, and you can analyze it with averages and all of those tests. The advantages of visual analog scale: it provides continuous data, means and standard deviations, as I already mentioned, can be calculated, and tests based on the normal distribution are possible, such as independent t-test, paired t-test, one-way ANOVA, paired ANOVA. Statistical power is greater than for Likert scale and other categorical rating scales, so it is possible to detect equivalent differences even with smaller samples. So that is another advantage of visual analog scale. But what are the disadvantages, on the other hand? Not true measurements, and they represent a subjective assessment. Two individuals with the same level of pain would give different readings. Hence, the clinical interpretation of a specific value is hard to define, although attempts have been made to do in the pain field by comparison with other data, as we say that the pain of a cancer patient is 9 to 10. So we try to compare it, but still it is subjective. Visual analog scale scores are often skewed, and so some transformation of the data may be needed before analysis for applying the parametric tests. If there are zeros, these cannot easily be transformed, and it may actually have a problem in terms of analysis. Numeric rating scale, on the other hand, this is a Likert scale that behaves much like a visual analog scale and is sometimes used if it was a visual analog scale. But the benefit is that it does not necessarily have to be a 10 centimeter line. It just need to be divided into 10 equal parts. So it is much usable and easier to use. Consists of a numerical scale like VS, but with verbal descriptors at the ends and numbers marked along the line from 0 to 10. And numeric rating scale data is therefore discrete, but it is often perceived as continuous, and it can be used as a continuous variable for analysis, and you can calculate the mean and standard deviations out of it. And that's how usually researchers use it, and I have personally used it in my researches as well. Now, choice of scale. What should we use? Categorical scale or visual analog scale? So where it is feasible to use visual analog scale, it is preferable as it provides greater statistical power than a categorical scale. So whenever feasible, use VES. So many studies in pain field use several tools to assess pain. So whenever that is the case, so have VES, they have VES as well as categorical scales. So a sensible approach or a correct approach would be to use VES as the primary outcome measure and the desired categorical scale as secondary outcome measures or variables. And that's would be the best way to do it. So thank you for watching this lecture. I hope you learned a lot out of it, and keep on watching sqadia.com for more lectures like this. Thank you very much.